Welcome everyone to today's lecture on primary esophageal motility disorders. In this comprehensive review, we will delve into the intricacies of various disorders, their etiology, pathophysiology, clinical presentation, diagnostic evaluation, and management options. By the end of this lecture, you will have a solid understanding of the complexities involved in the diagnosis and treatment of these disorders. Primary esophageal motility disorders, like achalasia, involve loss of peristaltic contractions in the esophagus and impaired relaxation of the lower esophageal sphincter, LES. Symptoms include dysphagia, chest pain, and weight loss. Diagnosis is through clinical evaluation, imaging, and esophageal manometry. Treatment includes medication, endoscopic procedures, or surgery. Diffuse esophageal spasm, DES, is a motility disorder characterized by simultaneous contractions in the esophageal body. Clinical presentation includes dysphagia, chest pain, and regurgitation. Diagnosis is done through esophageal manometry. Treatment involves medication and behavioral interventions. Nutcracker esophagus, also known as hypertensive peristalsis, is a primary esophageal motility disorder characterized by hypertensive, high-amplitude contractions in the esophageal body. The etiology of nutcracker esophagus remains unclear, but it is thought to be multifactorial, involving abnormalities in esophageal smooth muscle contractility and neurotransmitter dysregulation. Clinical features of nutcracker esophagus include chest pain, dysphagia, and regurgitation. The diagnosis is made through esophageal manometry, which reveals high-amplitude, simultaneous contractions with normal lay pressure. Management options for nutcracker esophagus typically involve pharmacotherapy. Calcium channel blockers, nitrates, and low-dose tricyclic antidepressants have shown efficacy in reducing symptoms. Lifestyle modifications, such as avoiding trigger foods and beverages, can also complement pharmacological interventions. Hypertensive lower esophageal sphincter, HLS, is a condition where the lower esophageal sphincter has abnormally high resting pressure. It is diagnosed through clinical evaluation, esophageal manometry, and endoscopy. Treatment options include medications and minimally invasive procedures like endoscopic myotomy. Jackhammer esophagus, J, is a primary esophageal motility disorder characterized by high-amplitude contractions in the distal esophagus. Clinical features include dysphagia and chest pain. Diagnosis is made through esophageal manometry. Treatment involves medications and behavioral modifications for symptom reduction. Distal esophageal spasm, DES, is a motility disorder marked by simultaneous contractions in the distal esophagus. Diagnosis involves evaluation, barium swallow, endoscopy, and esophageal manometry, while treatment options include medication and lifestyle changes for symptom management. Esophagogastric junction outflow obstruction, EGU, is a primary esophageal motility disorder characterized by impaired relaxation of the esophagogastric junction during swallowing. The etiology of EGU is multifactorial, involving abnormalities in smooth muscle relaxation, neural control, and arousal mechanisms. Clinical features of EGU may include dysphagia, chest pain, and regurgitation. Diagnostic criteria involve a combination of clinical evaluation, barium swallow, endoscopy, and esophageal manometry. Esophageal manometry reveals impaired relaxation of the esophagogastric junction during swallowing. Treatment modalities for EGU depend on the severity of symptoms. Mild cases may benefit from lifestyle modifications and acid suppressive therapy. In more severe cases, endoscopic dilation or surgical interventions, such as myotomy, may be considered to improve esophageal function. Functional esophageal disorders encompass a broad category of esophageal conditions characterized by symptoms without identifiable structural or motility abnormalities. These disorders include functional chest pain, functional heartburn, and globus sensation. In contrast to primary esophageal motility disorders, functional esophageal disorders do not exhibit specific motility abnormalities on esophageal manometry. Evaluation involves ruling out organic causes through clinical evaluation, barium swallow, endoscopy, and esophageal manometry. Management strategies for functional esophageal disorders primarily focus on symptom control. Acid suppressive therapy, behavioral modifications, and psychological interventions form the cornerstone of treatment. High-resolution esophageal manometry, HRM, is an advanced tool that provides detailed information about primary esophageal motility disorders. Its benefits include greater accuracy in diagnosis and the ability to guide treatment decisions. However, HRM is not universally accessible and requires specialized interpretation. Achalasia, a primary esophageal motility disorder, is diagnosed using a comprehensive approach. High-resolution manometry, HRM, Confirms the diagnosis by showing absent peristalsis and impaired lower esophageal sphincter relaxation. Treatment options depend on various factors, including patient preferences and severity of symptoms. Pharmacotherapy, endoscopic interventions, and surgical interventions are available. Advancements in medical research have opened new horizons for the management of primary esophageal motility disorders. Ongoing studies and clinical trials aim to identify novel therapies that can address the unmet needs of these complex disorders. Emerging treatment options include peroral endoscopic myotomy with submucosal tunneling, endoscopic fundoplication, and magnetic sphincter augmentation. These procedures offer the potential for minimally invasive interventions with excellent efficacy and safety profiles. Future directions in the management of primary esophageal motility disorders involve exploring the role of advanced technologies, genomics, and personalized medicine. Collaborations between gastroenterologists, surgeons, radiologists, and basic scientists are essential in advancing the field and improving patient outcomes. Future research in primary esophageal motility disorders focuses on technology, genomics, and collaboration. Innovations in imaging and genomics can improve diagnosis and treatment options. Interdisciplinary collaboration is key. Advancements promise better outcomes and personalized care for these complex disorders. Thank you for joining me in exploring primary esophageal motility disorders. We have covered the causes, symptoms, diagnosis, and treatment options for various disorders. Now you are equipped to handle these conditions in your future medical practice. Keep learning and embracing future advancements. Good luck in your careers.